Good morning. I have the distinct pleasure of introducing Dr. Boyd Gillespie this morning. Dr. Gillespie hails from beautiful Charleston, South Carolina, where he's professor in both otolaryngology, head and neck surgery, and molecular and cellular biology and pathobiology in the craniofacial biology division at the Medical University of South Carolina. He graduated magna cum laude from Davidson College, and then went on to complete both medical school and his residency at Johns Hopkins. They liked him there so much that they kept him another year to do a fellowship with Dr. Charlie Cummings, one of the leaders in our field, as his preceptor. Dr. Gillespie is board certified in both otolaryngology and sleep medicine. He's quite prolific, having authored over 80 peer-reviewed articles, as well as having hundreds of presentations, invited lectures, and digital media publications. He is at present the director of both the MUSC Snoring clinics and the Salvage Clinic, and is at the forefront for those fields in our specialty. He runs an excellent sleep surgery course, which I have personally attended and I strongly recommend to everybody. It's great. Dr. Gillespie has also been at the forefront of research with our present topic today, which is the hypoglossal nerve stimulation for obstructive sleep apnea, and having performed 7 implants during the START trial, which was published in the New England Journal of Medicine, and has done a total of 20 implants to date. We are privileged to have him here today to discuss his experience with this exciting new technology.
Thank you. I want to thank Dr. Jindon and Boris for having me. This is really a great opportunity. It's great to see all these faces here. I guess it's usually the residents on the back row, so I'm glad to see you guys here too. Also, I do want to say, follow up on something Dr. Jindon said. Your outcomes book is, a lot of people nationwide are taking notice of that. So I know it's a lot of work putting those things together. And as someone in my department is always prodding people to get their information in, it seems like a pain, but actually that is a very well done publication. And I think a lot of ways that our departments are going to be evaluated in the future is going to be based on these outcomes. So I applaud you for doing that. So today I have the pleasure of talking about upper airway stimulation therapy, which I think is really a new development in the management of sleep apnea patients. I think this is only the beginning. I think that very soon it will become the surgery of choice for many patients with obstructive sleep apnea. So I do have some disclosures. I do get some research support from Olympus and Inspire Medical, which is the maker of one of the devices we'll be talking about today. I also do some consulting for Medtronic and Olympus on sleep-related matters. So as Boris mentioned, I am from Charleston, South Carolina, so if I speak a little slowly, this is English that I'm speaking, but you might have to tune in. We're very proud of our program at MUSC. I've been there since we were about 5 or 6 faculty, and now we're 23 ear, nose, and throat surgeons and 2 maxillofacial prosthodontists, so we've really grown. We have been ranked in the top 30 by US News, and we just recently got nurse magnet status, so I'm hoping that's going to bump us up a little bit more. And as Dr. Jindon said, doximity is important. We try to get on there and rate our program, and we have been ranked as one of the top 10 residency programs based on that. Charleston's also gotten a lot of attention. It's recently was Condé Nast #2 city in the world. I don't know which is #1. It might be New York. I'm not sure. But lovely city. We hope that you can come, but choose when you come, because if you're caught there when it rains, this is what it looks like in the streets. People get their boats out and kind of boat down the street. But it's no problem. We're used to a little bit of rain there. So there's someone special in the audience I'd like to recognize today, Dr. Kanta Ahmed. Kanta, can you? Kanta's been a friend and mentor to me in the sleep world. Before I actually got boarded in sleep, Kanta was at the Medical University of South Carolina. She's a wonderful teacher in sleep medicine. She's currently at Winthrop Hospital on Long Island. I asked her to come here today. She graciously decided to come, but she's not only a wonderful physician, she's an author, commentary, humanitarian, and a freedom fighter. I mean, Kanta gives voice to a lot of people around the world who can't speak up for themselves. And I mean, she does it under no threat to herself, I'm sure. And just want to let you know that a lot of people in South Carolina are praying for your safety and want to encourage you. So thank you so much. So why do we treat sleep apnea? Well, as you know, it's strongly associated with cardiovascular disease, among other metabolic issues. So almost any chronic issue you look at, there's going to be an association with sleep apnea. And these associations are very strong. And nowadays, as we're being evaluated on our management of these disorders, whether it's heart arrhythmia, whether it's obesity, whether it's hypertension, and we're going to start losing payments as these patients are poorly managed. We have to manage the whole spectrum. Included in that spectrum is cardiovascular disease. I do treat cancer, and when I treat cancer, we look at a lot of these Kaplan-Meier curves. Well, this is a Kaplan-Meier curve for sleep apnea. And as you can see, there's a strong relationship with mortality if you follow these patients out over the years. It's almost like stage 1, stage 2, stage 3, and 4 squamous cell carcinoma. So obviously, these are the patients we're highly interested in, because if you follow them out long enough, if they're untreated or undertreated, they're going to have a high mortality rate. So CPAP is still the first line. We're not trying to replace CPAP. I don't think there's any surgeon, sleep surgeon in this country who's trying to replace CPAP. We recognize its value was a wonderful development. It's still the first line treatment for moderate to severe sleep apnea, and it's especially good in patients who have multiple cardiovascular risk factors. And it is the first thing that all patients should start with. The problem is that there's an adherence problem with CPAP. You look at the best clinics around the world, some of which are in Scandinavia and some countries that have very good follow-up and support of their patients. There's kind of a ceiling effect with CPAP, and it's generally at about 2/3 of patients can tolerate it fairly well for a prolonged period of time, but about 1/3 of patients really don't take to CPAP at all. So if you look at large longitudinal studies that have been done, about anywhere from 46 to 83% of patients report to be non-adherent to CPAP or use it less than the recommended 4 to 5 hours per night. And this is persistent. We've tried different masks, we've tried different pressures, we've tried different machines, different settings, and there's still that difficulty in some people getting them to be compliant with therapy. And that's an issue because certainly payers and governments and various things like that, they see the data on CPAP and the data looks good. I mean, you put someone on CPAP in a lab for one night, you cure their sleep apnea. The problem is this is a lifetime disorder. There is no cure for sleep apnea. CPAP's not a cure. Surgery's not a cure. Dieting's not a cure. It's a lifetime chronic disorder similar to diabetes or hypertension. So these groups would like to have CPAP for everyone, but we know it's more complicated by that. We have to, as physicians, take a more personalized approach, looking at individual patients' clinical, physiologic, anatomic, and even molecular factors. So I think surgery really has 3 roles in obstructive sleep apnea. One is as an alternative to CPAP, and I do think there's certain people who fit that. Those are people with mainly mild sleep apnea, upper airway resistance syndrome, or snoring. That group of patients, CPAP may be an option, but minor surgery may be an option, oral appliances may be an option. There's a lot of options for those patients. Surgery can be an important adjunct to CPAP. So if a patient's having trouble with nasal obstruction or nasal blockage, often treatment of that can help their CPAP usage. Or sometimes if they're only using it 4 to 5 hours a night, but sleeping 2 hours a night with it, minor surgical procedures can help cover them during the time when they're not on their CPAP. However, there's another group of patients. This is surgery salvage for CPAP failure. And I use this salvage, I borrowed this term from cancer surgery. I still do cancer surgery. I treat a lot of my patients with upfront chemoradiation therapy. And there are certain cases that works very well 2/3 of the time, but 1/3 of the time, those patients fail chemotherapy and they need to come back to us for surgical salvage. It's a more difficult surgery. They're a more difficult patient population. They have more severe disease. And that's really what we're facing with this population with sleep apnea. We're trying to do surgical salvage of their failure. And this is another important concept. Surgical salvage does not equal UPP. I think there's a misconception among sleep specialists out there that UPP is the only game in town. And what we need to educate them is that that's not the case. It does not equal. And even this article that's often quoted by Sher et al. From 1996, that UPP in unselected patients has a 41% chance of success. It also shows that if you add tongue procedures, 2/3 of the people can reach surgical success. And that's getting close to the success of CPAP. And this is in a group of people who've already failed CPAP. So it's actually worth thinking about surgery in the treatment paradigm. So surgical salvage equals UPP plus or no UPP at all. There are certain people who don't need the UPP and may do well with other therapy altogether. So when we're talking about that other therapy, is it all about the tongue? Well, partly so. So when we're thinking about salvage surgery, this is kind of the grab bag of procedures that we have to go to. There's UPP, expansion pharyngoplasty, genioglossus advancement, tongue-based radiofrequency, lingual tonsillectomy, partial glossectomy, hyoid myotomy and suspension, tongue suspension, MMA, hypoglossal nerve stimulation. And if you remember from your surgical training, there's always that adage that the more options you have for a surgical treatment, the less well each one likely works. And that's definitely true in this case as well. But we can improve our outcomes if we improve our patient selection. And that's really what we need to do. But this has been the difficulty for sleep surgeons and also just general practitioners who a lot of the burden of the care of sleep apnea patients falls among the general ENT doctor out there in practice. So it's important, critically important, if you're going to do surgical salvage on a patient to get proper anatomic localization of sleep apnea. And there's various ways that have been tried to do this over the years. There's certainly awake endoscopy with Muller maneuver. That's something we all do in our office. It's somewhat helpful. It gives you a bit of a idea if someone where their anatomic location of collapse is located. I, however, did a study looking at my correlation of my Muller maneuver with my diagnostic sleep endoscopy, and Muller maneuver is about 65 to 70% accurate. So about 1/3 of the patients, I was misclassifying where they were collapsing. You can use pressure catheters, but that's obviously uncomfortable. It's hard to sleep with that. It's mainly for research purposes. Cephalometry is often used, especially by my oral surgery colleagues. It gives good bony anatomy, but it gives poor soft tissue definition. Same for CT scans. Fluoroscopy has been used in children, but it's a little bit fussy. It's radiation, poor soft tissue definition. Dynamic MRI is very fascinating. This may be something we integrate more as these protocols become more available. I just heard some talks by Jose Barrera last week in Colombia, and he's done a lot of work on dynamic MRI. So this may be something we should consider. There are still some concerns about sedation or allowing a patient to go to sleep in an MRI machine when there may not be complete control of the airway. And then there's drug-induced sleep endoscopy. And the reason we're going to talk just a moment about this is because this is a critical step in selecting patients for upper airway stimulation therapy. So drug-induced sleep endoscopy, it's easy to perform, it's relatively low cost. It does allow you to visualize different levels of the airway, including the nasal, nasopharynx, oropharynx, hypopharynx. You can do real-time correlation with what you're seeing on their pulse oximetry. It's been shown to be safe in thousands of patients that have been studied. And it can improve your surgical outcomes by helping you identify sites that need surgery while avoiding unnecessary surgery on other sites. You can also do manipulations or fittings of oral appliances during this to make sure that you have the right orientation and oral appliance in place. You do need a team to do this, though. So you have to have a cooperation and understanding among your anesthesiologists. Generally, when they're dealing with a sleep apnea patient, they just want to get that tube in as fast as possible. And you have to teach them, this is not what we're doing. We're going to actually watch what happens to them every night. So they are going to desaturate some, but this happens to them night after night. We're here, we're going to control the airway. You use pulse oximetry, blood pressure monitoring, EKG, BIS monitoring. That's a bispectral analysis. If you have that available, it's helpful. Have a high resolution flexible nasopharyngoscope, and you want to prepare their airway, typically with some glycopyrrolate and oxymetazolam beforehand. You can give them a little 100 mics per kg bolus of propofol, and then do sleep maintenance at 50 to 75 mics per kg per minute. And then you do your endoscopy. Once you're observing that they're no longer verbally responsive, they're having some snoring and mild obstructions. Here's a patient of mine. He's lying supine and he's awake right now, so I'm doing the Muller maneuver. I'm having him breathe in against his closed nasal cavity. You can see a little bit of narrowing of his lateral walls when he does that. and you'll see that he has a very full base of tongue, and I'm trying to get him to make a snore sound there, and you can see some vibration of the soft palate. But you'll see how his airway changes, and you'll see why this guy has severe sleep apnea as we start to have him drift off to sleep. So now this is at early stage sleep. He's starting to get into rhythmic breathing. You can see he's starting to have almost circumferential collapse of his airway. And but this is still kind of early sleep. You have to be patient with sleep endoscopy. If you just take your first view, you're going to miss something. So you really have to allow the patient to get into a nice, steady rhythm with sleep. But you can see that it's not just lift of his soft palate. He's having collapse of his lateral walls, as well as some collapse of his posterior wall. Now he's having an apnea. You can see a complete collapse at the level of the velopharynx. And I'm going to break that apnea by passing my scope through that basically sphincter of his airway. And it's really fascinating what you see going on at his lower airway. So you'll see that his tongue is actually completely collapsing the supraglottic structures. So this is why sleep surgery is not successful. The forces that we're fighting against are tremendous. So it's part of this, you could say this guy has a big tongue, he has a floppy palate, so it's partially anatomic. But a lot of his problem is actually tonal. It is a tonal issue that we're dealing with, and you cannot remove enough tissue to open a gentleman's airway like this. We do have ways of evaluating the airway on diagnostic sleep endoscopy. One of the favorite mechanisms now is the VOTE scale. It's easy to use. It actually has been validated to some degree, and it allows us to figure out several things. One is we can figure out the site of collapse, the velopharynx, oropharynx, tongue, or epiglottis. That's what the VOTE stands for. The degree of collapse, whether it's none, partial, or complete, and also the pattern of collapse, which can be very important in what surgery we decide, whether it's anterior-posterior collapse, lateral collapse, or concentric collapse. This is a very difficult group of patients to deal with, the concentric collapse. So when you're doing your drug-induced sleep endoscopy, you have to observe your patient. I've gotten away from the BIS monitor, I've gotten away from everything. I just sit there and look at the patient and actually talk to them some while they're going through this to make sure they're at the proper level of sedation. So if the patient's awake, trying to communicate with you, or non-cooperative, typically you're going to get a false negative and you may miss sites of airway collapse. In the correct range, the patient will be asleep with steady breathing, non-arousable with verbal stimuli, arousable to physical stimuli. They'll be snoring, having apneas with mild desaturations. And then you're going to get your true positives, which are likely representative of collapse at their soft palate and hypopharynx. If you have too much sedation, the patient's not going to be arousable with physical stimuli. You're going to have to do jaw thrust to maintain their airway, and they're going to have sustained deep desaturations and central apneas, and you may get false positives. So if you give anyone in this room enough drug, they're going to have onset of apnea. When you're thinking about your surgical salvage, I want you to think about, this is just a very simplistic thing to think about. And you're thinking about what to do with the hypopharynx. Ask yourself, is the tongue too big? And the tongue is too big in a lot of these patients. Eric Kazarian, I know, was here recently. He's done some research in showing that there are actually fat deposits in the tongue. And as we add body mass, our tongue enlarges. Okay, so the tongue may be too big. These people have actually acquired macroglossia due to fat deposits in their tongue. Those are the patients who may also benefit the most from weight loss therapy. Or is the box too small? Do these people have relative macroglossia? Do they have small jaws? Do they have orthognathic issues that have allowed their airway to be compromised? So that can be managed as well. Or is their tongue too lax? Do they have poor neural tone? So some patients are going to be a combination of these. Some patients are going to be, but just think about ask yourself these questions as you're evaluating the patient. So today we're going to talk really about the tongue too lax group, okay? And we know that neural tone is very important in maintenance of airway during sleep. There's been study, our main dilator during sleep is our genioglossus muscle. If that muscle is paralyzed, you see the onset of apnea. So here you have reduced activation in the genioglossus muscle. You have the onset of an obstructive apnea. What are some signs that your patient may have a tongue too lax? Well, there are some signs. one is often these patients are normal weight or just slightly overweight. Often their tongues do not look enlarged, so they're Friedman score 1 or 2. I also look at their sleep studies. Their supine to lateral sleep apnea worse. A 2-to-1 ratio is kind of a cutoff that I use, that I'm thinking something's going on with their tongue. Their tongue's falling back into their throat. Do they have worse REM-related sleep apnea? Certainly reduced tone even during REM is going to make it even worse. And then finally, the drug-induced sleep endoscopy, once I've looked at this, can help confirm whether or not they're truly having tongue collapse. So what do I do for these patients? Well, they have mild to moderate sleep apnea. I may think about a tongue suspension procedure, a hyoid suspension, or maybe even oral appliance therapy. If they have more severe sleep apnea, I do think now the best surgery for them is upper airway stimulation. So here's a patient with that. This was a relatively normal weight patient. You would do Muller maneuver like this and not really see any tongue collapse at all. You can see his entire vallecula. His tongue's fairly far forward. But as we sedate him and he starts to fall asleep, you'll see what happens to his tongue. His tongue just starts to progressively become ptotic in his airway until his airway completely closes up. So you cannot predict this in a awake patient. You have to do drug-induced sleep endoscopy to actually see this take effect. And here's what his tongue looks like. I opened his mouth during the OR, and you can just see his tongue just falling back into his throat. So a lot of these patients open their mouth, their tongue rolls back, and occludes their airway. So again, they have a normal-sized tongue with loss of tone. I'm thinking tongue suspension, perhaps, if they have mild to moderate sleep apnea, but hypoglossal nerve stimulation and more severe sleep apnea. So what's our rationale for upper airway stimulation therapy? Well, we do know that there is this decline in upper airway neuromuscular tone with sleep. Some of that decline may be due to reduced sensory mechanisms as well. We do know that the superior laryngeal nerve has a feedback loop to the genioglossus. So, people who have paralysis of that nerve that nerve actually senses negative airway obstruction. So, if you have obstruction of the soft palate, the superior laryngeal nerve can sense that negative pressure, send a feedback loop to the genioglossus that can actually open the airway. So patients with impaired superior laryngeal nerve function can suffer onset of sleep apnea. And that's something to consider in your patients who are post head and neck surgery. It's also important to realize that the cause of collapse is independent of anatomic soft tissue obstruction. So soft tissue obstruction is part of the problem, but not the problem in most of these patients. Also, the genioglossus is the main upper airway dilator involved in maintaining airway patency during sleep. This was actually in preclinical animal studies. Alan Schwartz and his group at Johns Hopkins, this was back in the 90s when I had the pleasure of working with them, showed that selective stimulation of the hypoglossal nerve in animal models resulted in reduced upper airway collapsibility. So using the Starlin model of P critical closing pressure, it's kind of a hard concept to think about, but if you think about it, the less negative pressure it takes to close someone's airway, the more collapsible their airway is. So we would test this in a cat model by hooking up a suction tube to the airway and applying vacuum. So the more collapsible the airway, the less. So some people with sleep apnea actually have positive pressure is collapse. So if it takes 8 of CPAP to keep your airway open, your airway actually collapses at positive pressure. So a pressure of 4 is not enough to keep your airway open. So the higher the P crit, the worse your sleep apnea. So, but by stimulating the hypoglossal nerve, you can actually decrease this critical closing pressure. And in these early studies, they actually did some studies in humans. David Isley and his group would do a neck dissection, and the sleep doctors would come in and put electrodes on the hypoglossal nerve, and we'd see what kind of response occurred. But they found out that they also did some transoral fine wire electrodes in the genioglossus muscle and found that this could increase the maximum inspiratory airflow during sleep by 2 times without stimulating arousal. So this was kind of the beginning of this thought that we might could stimulate the nerve. So here's an example of the upper airway stimulation effect on an epoch from a sleep study. So here you have a patient, poor tone in the genioglossus muscle, having obstructive apneas and decreased airflow, serial desaturations. restoring that tone with a pulsatile effect in the genioglossus muscle restores a normal airflow pattern and restores oxygenation, more importantly. So the Inspire 1 trial was in the late 90s, involved 8 patients implanted with a hypoglossal nerve stimulator, a pulse electrode, and at this time they weren't really sure how to measure when to tell the electrode to fire. They knew that they needed to get some sort of measure of thoracic pressure, so they had a transsternal pressure sensor. So it was a fairly involved surgery. They had to basically drill a hole in the sternum and put a pressure sensor there. They found that in these patients, actually, they experienced a mean decrease in their HI from 52 to 23, so showed that this was a feasible concept. There was no evidence of sleep arousal with stimulation, and no detrimental effects on nerve and muscle for use over 6 months. The problem was that the technology wasn't quite there. They were suffering electrode failure in most of these patients and device failure. So eventually, the coupling of the electrode with the nerve wasn't quite worked out, and there needed to be some more technological advancement. But at least this showed that this was a feasible concept. The Inspire 2 system, about a decade later, came out, and this is really essentially what we have now. So it took improvements in these electrode technologies, and they approached these patients to figure out a better way to do it. So the current technology is a implantable pulse generator, generally placed on the right side so it's not confused with the left side cardiac pacemaker. It involves the stimulatory lead that's placed on a very certain location on the hypoglossal nerve. We'll talk about that in a minute. But also a sensory lead that's placed usually between the 4th and 5th ribs, between the intercostal, external and internal intercostal muscles. And that detects breathing, and it tells where in the cycle of the respiratory cycle for this to activate. And so that's obviously a lot easier than drilling a hole in the sternum. The pulse generator is the size of any other cardiac implantation. Actually, it's really the same thing. It's the same size as a pacemaker. The patient's given a remote control where they can control their parameter sum and activate it at night when they go to sleep. And then the programmer is given a tablet that we can actually change different parameters to optimize therapy. The surgery does involve 3 incisions. This is a patient who's had the surgery, 1 incision and a natural skin crease of the upper neck, kind of similar to a submandibular gland incision. Another one, several finger breadths below the clavicle for the pulse generator, and a third in the mid-axillary line for placement of the sensory lead. And this is done obviously under general anesthesia. So the incision is very similar to a submandibular gland excision, but you push it forward a little bit. So if I was doing my submandibular gland excision, I would probably have this a little further back. This is going to go a little bit further towards the midline. And the reason is you need to get increased exposure on the distal hypoglossal nerve. And I'll show that to you in a minute. And just having this incision a little further forward helps you with that exposure. So during these cases, we do monitor EMG. We have EMG in the styloglossus muscle, which runs along the lateral surface of the tongue superiorly, and in the genioglossus muscle. So what we want to see when we're stimulating the nerve, once we have our electrode cuff on, is that we're getting great capture on our genioglossus, and we can also see that by visualizing, but also reduced capture of the styloglossus. We do not want to get the retrusor muscles, because if you place this electrode on the wrong part of the nerve, you're going to get what we call mixed activation, which is a tongue that gets very tense but often rolls back into the throat. You can actually make their sleep apnea worse if you're not careful where you put the electrode cuff. So this is why the surgery is fun. This is what makes the surgery fun. It's very physiologic and anatomic. You actually follow the hypoglossal nerve out, you observe the different branches, and you place the cuff on the branches that are going to give you the best effect. And those branches are the branches to the genioglossus. We'd often include the branch to the geniohyoid as well, because that gives some anterior support to the tongue. But we want to avoid the branches to the hyoglossus and the styloglossus, which are the retractor muscles. This is a great diagram. This was actually done by one of the Inspire representatives. He actually did this on his kitchen table, and I found it, he used some flank steak and spaghetti. So we had a great spaghetti dinner last night, so I won't need spaghetti for a while. But so but this really shows the anatomy, and it shows it well. So the first landmark that you're looking for is the digastric sling, and you can feel that because it's attached to the hyoid. So you cut down to the hyoid, you find the digastric sling. Then you look above that sling, and you're going to see on top of the hyoglossus muscle the hypoglossal nerve. So you just follow that nerve along that hyoglossus till you reach the mylohyoid. Okay. So the mylohyoid is like a curtain. You pull back the curtain, and then you're starting to see the nerve branch out. These branches going up are going to our retrusor, so we do not want to get these up branches. These are going to the styloglossus and to the hyoglossus. These are the branches going to the genioglossus and the geniohyoid. This is where we call this the plunge point. When it gets to the edge of that muscle, it kind of plunges and divides out. This is why it's fairly delicate. These branches can be quite small in some people, and you're not doing the well-myelinated trunk here. You're doing these finer branches out here distally. How about the placement of the sensory lead? Well, this is probably the thing that most ear, nose, and throat doctors feel the least comfortable with, is operating on the chest. You're somewhat familiar with it from pec flaps. We don't do those as much anymore, so you have to get fairly confident. And some of these patients have quite thick chest walls, so it's important to actually have their arm extended, so that the first time I did this, their arm was down by their side and there was about this much adipose tissue I had to go through, which was not much fun. So keep their arm extended and in the mid-axillary line. And then you have to rotate the pectoralis major muscle out of the way to get down to the ribs. You can feel the ribs, so you know you're in the right area. But how do you know where the intercostal muscles are? This is where some of the latissimus is starting to interdigitate and can be a little hard to identify. Again, the same guy who did that diagram, Luke Lozier, I mean, he's a great guy, and I would encourage, once you start, to maybe bring Luke in for some of your implant. He pointed out something to me. He goes, those intercostal muscles look like packing tape. And he's exactly right. Packing tape that you use to tape up boxes, it has those little fibers in it. That's what the intercostal muscles look like. So you dissect down between the ribs until you see the packing tape, and then you know you're on the intercostal muscles. Then you have to create a tunnel between the external and internal intercostal muscles, and that tunnel has to be about 5 centimeters deep, so you're kind of blindly passing a Kelly clamp between those muscles. It was interesting. When I first started doing this, I said, this trial is going to have a pneumothorax. To date, there's been about 400 implantations worldwide, and no reported pneumothorax. But I think it's harder to occur than we think. So once we get the sensing lead in, we actually have to verify that we're picking up good respiratory signals. So we attach the sensing lead to the IPG, and we analyze it with a remote analyzing device. And we actually put some pressure on the patient's chest. We give them some Valsalvas, and we make sure we're getting a good respiratory flow signal. Then once we've hooked up the stimulation electrode, we have to confirm that we're getting good signal, and you're looking at your EMG, but you also can just look at the patient's tongue. So here we are stimulating the tongue. You can see we're getting good tongue protrusion. So this is obviously kind of super therapeutic levels, but we just wanted to see it. So this is always a fun part of the case. Everyone gets very excited seeing the tongue do that. So the neat thing about this is that this fits very nicely into a sleep program. The concept of how to get patient therapeutic is very easy to learn by sleep technologists, because it's very similar to CPAP in a lot of ways. It is a titration very similar to CPAP. That's why it worked. This is a great surgery and a busy sleep program. This titration occurs in the laboratory. The sleep technologist will actually change the parameters and increase the amplitude of stimulation, verifying that the patient's not overly arousable, but verifying that the apneas and hypopneas have been adequately treated. And they do it in a stepwise fashion like they would with a CPAP titration. So how do we stimulate? This is interesting. We found that the best results are actually if we start stimulation at in expiration. And there's a lot of thought that at in expiration, the airway is at its most collapsible. And then once you start the inspiration, the negative pressure causes it to collapse. Well, So we actually overlap stimulation at end expiration, so it can time it based on the sensory lead, and it carries about 2/3 of the way through inspiration, and then it pauses. There's various parameters that we can play with to optimize therapy. The most simple one is amplitude. That's just the amount of energy delivered to each pulse. We can also change the pulse rate, which is the hertz, the rate of firing, and the pulse width, amount of time that the nerve is exposed to stimulation. And we can go from bipolar mode to unipolar mode. There's various ways we can play with it to optimize therapy. Here's a patient of mine. This gives you an idea of what this can do. So this is a patient of mine who, this is on awake endoscopy. You can see he has a fairly large tongue. He has a little bit of a retroflexed epiglottis. He's awake. I have him stick out his tongue there. But when his tongue's in, you can see that he has a fairly narrow hypopharynx, and this is with him completely awake. So he's sticking out his tongue again. But his natural, so this is what it looks like during drug-induced sleep. So he has some collapse of the soft palate. And we're going to look past that, and then complete collapse of the base of the tongue. I mean, so when he's having apneas, there's just no airspace, very, very little airspace. You see his tongue just kind of keeps collapsing down until he has a full apnea. See nothing but tongue. This is what happens when we turn on the stimulation. So it's time with his breathing, and you can see it reestablishes his airway close to what his awake airway is in supine. So this was interesting. When they first came out with this, I said, will unilateral stimulation be enough? And you can see from this, unilateral stimulation of the genioglossus is enough to establish the airway. So this is time with his breathing. So you may wonder, is their tongue sticking out of their mouth? Their tongue's not sticking out of their mouth. Okay, it is moving, obviously, but it's mainly the base of the tongue that is moving. So it's usually at these super therapeutic levels that we actually get tongue protrusion. So when the phase 1 trial of this involves some patient selection and coming up who's the best patient for this device. And in the phase 1 trial, they didn't know. So they just implanted patients they thought would benefit from this. But they found that there was a certain group that benefited more than others. And that group were generally patients with an AHI less than 50 and a BMI less than 32. Okay, so when they looked at the 10 patients who had that, 6 out of the 10 were very good responders, 4 were not very good responders. When they looked at the other group that had an AHI greater than 50 and BMI greater than 32, very poor response to this therapy. This is just a very severe group, generally a lot of parapharyngeal fat. So if anyone can come up with a way to treat that, maybe Dr. Jindon robotically or something, come up with a way to defat these people's parapharynx, I mean, there may be no surgical options. So this was the first clue that this may be the group of patients that we want to concentrate on. There was also a group of astute physicians involved in this phase 1 trial in Antwerp who found that when they looked at the sleep endoscopy of these patients, they found that it was patients who had complete circumferential collapse at the level of the velopharynx had poor response to this therapy, where those without complete circumferential collapse had good response. So these are the patients with, these are small numbers, but the 3 patients without palatal circumferential collapse had very good response to therapy at 6 months, where those with complete concentric collapse of the soft palate did not. They had poor response. Again, this is somewhat related to BMI, but not completely. I'm going to mention Apnix. Apnix is a different company that made a device, but this again just shows the feasibility of this approach, and it's good to see that other investigators are working on this. This company went out of business, but there are other companies working on their devices as well. So this study, Apnix trial, had 21 patients, mean age of 50-40 years. Patients used the therapy fairly well, 89% of nights, average of 5.8 hours a night, so they were very compliant. And their mean AHI dropped from 43 to 19. Their Epworth Sleepiness Score improved. Their FOSQ, Functional Outcome of Sleep Questionnaire score, improved. They did have 2 serious events, one infection requiring device removal, and one stimulation lead cuff dislodgement requiring replacement. But so it's encouraging to see that other people, other devices are kind of showing improvement as well. The STAR trial, which was a phase 2-3 trial that was just completed a couple of years ago, looked at the Inspire device in a big fashion. We implanted 126 patients over, I think it was 22 study centers. And this was published in the New England Journal of Medicine. We were very proud of that. And I'm just going to run through that. So the STAR trial, based on that early phase 1, we were able to better select our patients for this therapy. So in the STAR trial, we selected patients under BMIs under 32. Now the FDA has not specified that. All they say is that it has not been studied in people with BMI greater than 32. So I think that requires some selection. I mean, there are going to be people who mainly have lower body fat or obesity who may be very thin up top, who may respond well to therapy, but that's going to be on an individual basis. Certainly, we wanted all patients to have tried CPAP and been found intolerant. So I put a question mark here because I still don't think we have a good idea what we mean when we say that patients are CPAP intolerant. And when you're thinking about implanting a $20,000 device with a $10,000, $15,000 surgery, I think we have to get a better concept of what we mean by CPAP intolerance. That's why we need sleep physicians to be involved and really document who is not wearing their CPAP well and who is. The patients need to have moderate to severe sleep apnea. In the STAR trial, we limited this from 20 to 50. The FDA expanded this to 65, and the reason for this is pretty interesting. So all these patients who were enrolled in the trial had a sleep study, and then they had a sleep study immediately before implantation. And we found that actually immediately before implantation, a lot of these patients had worse sleep apnea than was shown on the first sleep study. That's just part of the variability of sleep study. But based on that, there was enough of them in that category who responded well that the FDA felt confident in expanding that AHI. Also, they should have less than a quarter of their events being central apnea. Also, we had to do drug-induced sleep endoscopy on all patients to rule out no complete concentric collapse of the soft palate. So how many people did we screen? Well, we had to screen 929 patients to implant the 126. And honestly, that is not that far off from what I'm seeing in my practice. So I'm seeing about 6 or 7 candidates to find one candidate I think is really good for the therapy. So, and this technology is new. We want it to work well. We don't want to give it a bad name. You're going to want to implant the best candidates. And can't stress that enough, because if we just implant everyone and get poor results, and it's not going to help this treatment going forward, especially as we have to make arguments with payers and other government organizations who are covering the cost of this. So, but that's about right. But one of the interesting things was, one way a lot of people screened out was that they came in, they had a history of sleep apnea, they had been put on CPAP, they were doing poorly, and we studied them. About 15–20% of people screened out because they did not have sleep apnea, or they at least did not have moderate to severe sleep apnea. A lot of them had very mild sleep apnea. So they came in being told, oh, you had the worst sleep apnea ever, and they found out that they actually did not have much sleep apnea at all. So that was the major reason people screened out. All these patients had tried CPAP. 18% had tried oral appliance. 17% had had previous airway surgery. Several 6% had had CPAP, oral appliance, and surgery. So how about CPAP in their use in this group of patients? Well, we found that 43% were still trying to use their CPAP, but not using. They were using it maybe 1 to 2 hours a night. 47% had just quit wearing it altogether and refused to go back to it. And then about 10% we had trouble identifying in this retrospective review of what happened with their CPAP. But this was kind of the course of CPAP quitting in the people who quit their CPAP. 19% of those who had quit at 1 year. And you can see as you follow these patients out, there's a steady increase in their abandonment of CPAP. So another key feature here, this is a chronic disorder. Our outcomes are going to be evaluated based on our ability to manage chronic disorder. we're going to be evaluated on sleep apnea like we are on diabetes, on hypertension. We have to follow these patients. We have to make sure that they're getting the care that they need to get. So out of those groups, comparing the group that abandoned their CPAP to those who are still attempting their CPAP, there's really not much differences. It's interesting, those who are still attempting CPAP, to me, still had daytime sleepiness and still had poor functional outcomes of sleep. So even though they were using their CPAP, they weren't getting the benefit of it. So how about oral appliance therapy? So out of 171 patients that tried oral appliance therapy, 37% were still attempting it, but 63% had abandoned it. And it's kind of similar to CPAP. You can see that people will try it for a year or two and then abandon it. And with any chronic disorder, patients over the course of their lifetime, depending on their medical needs, may need a variety of interventions. We may start with CPAP. We may move to oral appliance. And then finally, we may go to surgery with a certain group of them. So we just have follow-up is very key. So out of the baseline patients that we screen, here's just their baseline characteristics. It's very actually similar to the baseline characteristics of the people we actually implanted. So we eventually implanted 126 patients. Their average age were 54 years, 83% male. So they were slightly overweight, but not greatly overweight, with a body mass index of 28. Their mean AHI was 32, so not overly high, but certainly in that harmful range. 22 or 17% had had a previous UPP, and they were largely a normotensive or slightly hypertensive group. So this is the important part of the screen of this, is that was that earlier finding that complete concentric collapse at the soft palate patients do not respond well. And this is really what we're looking for on drug-induced sleep endoscopy. And these are examples that show the vast differences in airway. So patients who have this, what we call banana-shaped airway with kind of decent lateral airway ports at their velopharynx, respond very well. A lot of these patients, the main reason they're having palatal collapse in the first place is because the tongue, the dorsum of the tongue, is pressing against the palate and allowing the palate to fall back. You can't see that because we can't see the tongue here, but that's what's happening. And I know that because if I can grab their tongue and pull it forward, their palate falls forward. Whereas this circumferential collapse, these patients largely have collapse based on tongue, but also based on the palate itself, and also circumferential fat in the parapharynx. So this is what we're looking for in sleep endoscopy. Does the patient have this banana-shaped oblonged airway with AP collapse, or do they have this multi-directional collapse? These patients do not respond well. So it'd be nice if all patients fit these two categories. Unfortunately, you'll find that there's a lot of gray area in the middle, so it's somewhat of a judgment call. When we're looking at the collapsibility of these airways, on 122 patients underwent drug-induced sleep endoscopy as part of this trial. You can see that these patients have multi-level collapse. 94% collapse at the soft palate, 69% at the oropharynx, 93% at the tongue base, and 73% at the epiglottis. So the 23% of patients, however, had this complete concentric collapse. So that's roughly the number that's going to rule out on drug-induced sleep endoscopy. And that complete concentric collapse can come in various varieties. You can have collapse of the lateral walls. You can have collapse of the posterior walls. Anything greater than 75% circumferential collapse we consider complete concentric collapse. So roughly 20% of patients were not eligible for implantation based on this finding. Here's the problem though. Drug-induced sleep endoscopy is a qualitative examination, so it is very subjective. I actually asked the Inspire people to give me 65 blinded drug-induced sleep endoscopies that were part of the trial. And then I actually had 5 investigators grade these, and I compared our grading to each other. And this is what I found. I found that we actually agreed completely 66% of the time. Okay, we had pretty good agreement, 4 out of 5, 12% of the time. So I think 78% of the time when we're reading the same studies, we agree. That means 22% of the time there was definitely disagreement. One of the nice things about Inspire and what they're trying to do, they will allow any investigator, or it's not investigators now, people who are actually implanting. If you're implanting and you do a drug-induced sleep endoscopy and you have some questions, you think it's a borderline patient, you can actually upload that video to a site where investigators around the country can chime in and say whether or not they think it's a good candidate. So you can kind of do basically crowdsourcing to see if it's a good implant candidate. So again, so out of the videos that we reviewed, about 75% agreement. So it's important to remember that drug-induced sleep endoscopy is not perfect. It's qualitative, and it's really a judgment call. And if a patient's a borderline case, better to crowdsource it and get an opinion. When you're first starting out this therapy, I would recommend doing mainly the slam dunk cases. Okay. So how are these patients with complete circumferential collapse different? Well, they do differ in their BMI is slightly higher than the people without circumferential collapse, and also their neck size is bigger. Okay, so it's usually a reflection, again, of parapharyngeal and neck fat. So what were the outcomes of the STAR trial? Well, the main outcome that we were looking at was the apnea-hypopnea index. And again, we use the surgical terminology for success, which historically has been defined as a patient's success if they have an overall decrease in their HI of greater than 50% and an overall HI less than 20. Now, you can debate that all day, whether that's a good definition of success, but that's historically been what we've said success is. So in the STAR trial, there was a 66% responder rate at 12 months. So it's not perfect. About a third of patients were not surgically successful. So we still have work to do in figuring out why some people don't respond well. But not bad. It's as good as CPAP. And these are a group of patients who have failed CPAP. The oxygen desaturation index, which is also kind of mirrors the AHI, there was a 75% responder rate. This was looking at a greater than 25% reduction, at least 50% oxygen saturation reduction responder rate. And we saw a 75% responder rate. So if you look at mean score or median scores, the median AHI preoperative was 29 for the group, post-op was 9, overall 68% reduction. The median ODI pre-op was 25, 7.4 post-op was 70% reduction. When we looked at patient-based outcomes, such as functional outcome of sleep questionnaire, anything over 7.9 on that scale is considered normal sleep-related quality of life. These patients on average entered the normal range. And when we looked at the Epworth Sleepiness Scale score, that also normalized as well. Snoring is important to patients. We often forget that, but it is very important. 72% of these patients were very loud, intense snorers on a nightly basis, enough that the patients had to sleep apart from their spouse. Post-op, only 15% of patients had that sort of snoring. Also, we did a randomized control trial built within the trial where the first 46 responders to therapy, we then randomized them to either a therapy on or a therapy off group. And this is really just to show that the responses that we were seeing were due to the therapy and not due to some confounding factor. So here we are. These are the pre-op evaluations of these groups, the people who were in the on and off group. They were all responders at 12 months. But on the off group, we actually cut off at 13 months, cut off their device, and you can see they go back to towards their baseline severity. So this just shows that the effect that we are seeing is due to the device and not due to some confounder. And then when we cut them back on, you can see they go back to their therapeutic response. So when we look at adherence to therapy, unfortunately, right now, it doesn't give a smart card-like readout. Newer editions of the implant in the future will give that, but we can calculate the percentage of time that the device was on. There was, at 18 months, that's the latest we have published today, it was 84%. Now we have 36-month data, it's about the same. So 84% of people are wearing it all night, every night. As far as safety outcomes, during this trial, there were a couple of safety events that were considered serious. One was a implantable pulse generator that became loose in its pocket and was bothering the patient that had to be repositioned, and that happened in the first 12 months. And another one happened between 12 and 18 months, became loose and had to be repositioned. There was no unanticipated adverse events. Explants, there was one explant at 11 months. This was actually in a physician who had the device. He was an incomplete responder. He was moving away, and he said, just take it out. So they took it out. There was another one in a woman. She had a history of rheumatic arthritis with some septic arthritis. She had developed an infection. She was actually a therapy responder and was very happy with therapy. She developed an infection of the sternoclavicular joint. Because it was close to the device and they weren't sure, they took out the device. The device showed no signs of infection. And both explant procedures were uneventful. How about adverse events? Well, the main ones that I want to focus on are really two that are kind of unique. One is temporary tongue weakness. This was seen in 18% of patients. This is the real fear and danger of dealing with nerves, is you don't want to make someone worse. And you can make them worse if you actually weaken their tongue permanently or paralyze their tongue. The other is discomfort with stimulation. Now, we had to report all levels of discomfort, and a lot of this was fairly mild. And I think long-term, only 2 or 3 people complain of still some ongoing discomfort. So it's something patients habituate to and find very tolerable. Here, I have had one patient with tongue weakness. You'll recognize it. Here he is post-op, and you can see he has kind of deviation of his tongue to the weak side and some loss of tongue volume. This did, he actually had very small, tiny branches at that plunge point we talked about. So I just think my lifting and manipulation of those branches when I put on the cuff resulted in this weakness. This did resolve, and he is therapeutic now. So how about patients who've had previous UPP therapy? Well, they actually respond similar to patients who have not had UPPP. In the trial, those with previous UPPP had 71% success rate compared to 66% as a group. So because the patients had a previous UPPP, they should not be excluded from this therapy. Here's a patient of mine. This is just one case example. This was a 76-year-old male with a history of severe snoring and daytime sleepiness. He had a sleep study in 2010 that showed severe sleep apnea. His overall AHI was 46, low oxygen 68%. His CPAP tolerance was poor, secondary to discomfort and constant feeling that he was suffocating. He did have hypertension that was medically controlled. His BMI was 29, his Mallampati was 3, and he had smallish tonsils. Here's his drug-induced sleep endoscopy. You can see he does have complete collapse at the soft palate, but you can already tell he has a little bit more of that banana-shaped airway that we're looking for, okay? So when the tongue's out of the way, you see his airway and palate actually opens up quite nicely. So this is his PSG data that we did. So his total AHI at his baseline was 28. At 12 months, it was 2.2. This is on therapy. His supine AHI was 51. It was 5 at 12 months. Lateral 36, 1. And his Epworth Sleepiness Scale score had improved significantly. So this gentleman is extremely happy. The FDA did approve this device in June of 2014. It even made it in Times Square. So Gene Simmons, he has that long tongue. He might need the device at some point. But this didn't get approved. We are all very excited about that. But there is work to do, and there is more follow-up that we need to do. So I'm going to just share with you a little bit of the long-term outcome. So one of the questions we had, and one of the concerns whenever you're stimulating a nerve is the nerve going to habituate to this stimulation? Or are we going to get into this vicious cycle where we have to continue to increase stimulation over time to get the same therapeutic effect? And we're actually not seeing that. So this is good. At 36 months, the functional threshold of the device is holding. So the amount of amplitude or voltage that we have to deliver to the nerve has been consistent. So the nerve is not remodeling as far as we can tell. The nerve's not getting thicker or a callus on it that's causing us to have to ramp up stimulation. So that's good to know. We're also seeing sustained effect. So our median AHI at 36 months, 98 patients agreed to undergo a 36-month sleep study. These patients have been great, actually. They've really stuck with us through this trial, and they're actually having very good responses. So the ODI, again, oxygen saturation index, quite low at 36 months. FOSQ has been pretty much normal at 36 months. And Epworth Sleepiness Scale score has been maintained. So this data will be published shortly. How about snoring? So this is soft or no snoring. At baseline, only 17% of patients had soft or no snoring. At 36 months, 80% have soft or no snoring. This is important to patients, so it's important to their ability to reestablish a bedtime routine with their partner. This is an interesting thing, and this is something that we didn't naturally anticipate, but airway stimulation, even of the genioglossus, is a multi-level effect. There is coupling between the tongue and the palate. Part of it's just purely anatomic with the dorsum of the tongue. When it relaxes, you can imagine presses the soft palate to collapse, so bringing the tongue forward allows the palate to fall forward. But there's also a direct coupling of the palatoglossal folds. As you're pulling the tongue forward, the palatoglossal fold pulls the soft palate forward. And we've looked at this data. These are whether the patient had single-level collapse, two-level collapse on drug-induced sleep endoscopy, three-level or four-level collapse. It doesn't really matter. Stimulation of the airway can result in good therapeutic outcomes in all levels of collapse. How about multiple devices? Okay, so this is going to come up because a lot of patients with sleep apnea have cardiac issues. So this is a patient of mine. He had some cardiac history. I put in a upper airway stimulation, and he actually was doing quite well from this, but he started having some VTAC runs, and they wanted to put in a defibrillator. Well, it was kind of allowed us to do a neat little experiment. So we were able to, at the time of his defibrillator placement, actually test it against this device. So we cranked up our device to full level to see if it would be detected by his defibrillator. It was not detected. We then sent off the shock from his defibrillator to see if it affected the effect of our device, and it did not. So there was no communication. So we did dual testing. When they put in these defibrillators, they have to stop the heart and restart the heart to show that it works. So that was just part of the routine, but we were able to test that. We've also, since this past August, I implanted a patient who already had a defibrillator with the upper airway stimulation, and in that time we did not set off his charge to test it, but we were able to crank up our system to make sure there was no cross communication, and there's not. So these things have to be tested. Eventually, I think they may come out with one device that you can do both with. Because if you think about it, a lot of the people who are getting these are heart failure patients. Heart failure patients cost tens of thousands of dollars per year. Ones who are poorly managed keep going in and out of ERs and hospital units, and a large part of their poor management can be sleep apnea. So I would love for them to invent a device that allows you to do your defibrillator and also hook up to treat their sleep apnea at the same time. It'd be lower cost, and it may help better management. So there may be things like that in the future. How long does the surgery take? Well, at first, the surgery took us roughly 151 minutes to do. We did look at the learning curve of this, and it does reduce over time. Nowadays, it takes about an hour and a half for anyone who's done more than 5 implants to do the surgery, so not too long. 95% of the patients went home either the same day or the next day from surgery, and it was very well tolerated. We had them do light activity for 1 week, normal activity for 2 to 4 weeks, and then vigorous activity after 4 weeks. We looked at the learning curve of this therapy and found that with increasing experience, you do have reduction in surgical times. Again, it kind of peaks after the 5th implant, but generally surgeons who are doing this can get it down to about an hour and a half of surgical time. This is a nice thing. There's not much pain with this. If you look at pain scores compared to historic pain of UPP, UPP pain can be very severe, a 6 or 7 on a 10-point scale. And actually, sometimes the UPP is worse at 1 week. And we all know that because the pain's just not getting better and the patients are very sore. Very low postoperative pain. Most of my patients did not even need narcotics, which is also very important in people with sleep apnea. So we actually, when we do this, we make sure the patients go through the implantation protocol, If we implant them, we actually let them heal for a month without activation. They can use their CPAP during that first month. And then they come back to the office, and we actually activate them in the office. And that gives them a month to kind of acclimate to therapy. And then at month 2 is when we do their sleep study. You don't want to activate them in the lab. And that's one of the problems with CPAP sometimes, is that maybe we should acclimate people to CPAP before we even send them to the lab for a CPAP titration, because it's to do it for the first night can be quite daunting. So we actually let them get used to it. We put them on a range we think is going to be therapeutic, and then we actually hone in on the right range at their sleep study. And then long term, we can do various changes to optimize therapy. The predicted battery life is going to be about 10 years. So for a cardiac pacemaker, the battery life is about 6 years. It has to work more often throughout the day. This being used roughly a third of the time is predicted to be good for about 10 years. So there are different implantation systems out there. This is good news. I'm glad that there's going to be competition here. I think it's going to lower cost and make this therapy more viable and create technological advancements. MThera is a different system. It works by a different modality, and it's under a phase 2-3 trial currently. So I look forward to hearing the results of that trial. It works a little bit differently, whereas the Inspire system is phased with breathing and actually fires enough to cause a distraction of the tongue. The MThera system is not phased with breathing. It creates a constant stimulation of the nerve that creates a tonal response. So just a tightening of the muscles without an active movement of the muscle group. So it'll be interesting to see how that device fares. So some advantages of upper airway stimulation. It does address the pathophysiology of reduced neuromuscular tone. You can titrate it to effect. There's no permanent removal or alteration of throat tissues. It's less painful with faster recovery, potentially reversible. I think there's going to be spin-off applications that I'm excited about for dysphagia, stroke victims, cranial nerve paralysis. And there's 2 competing companies currently, which I think are good. So here's a patient of mine. He has, you can see, he has cerebral palsy, obviously. He has a very weak tongue and cannot tolerate CPAP. And he's likely to undergo this therapy soon. But this is the type of patient who was not in our trial initially. We may need to treat children with cerebral palsy with this in the future. He's a very big Clemson fan. I don't know if you guys barely even know about Clemson, but we're crazy about him down in South Carolina. So some of the disadvantages is expensive. Okay, so we need to select our patients well. We have to be judicious. However, if we truly are long-term preventing heart disease, preventing stroke, it's going to pay for itself. Over a 10-year lifespan, it can be very effective in therapy. I think it's going to work best in younger patients, people with lower BMI, hypotonic tongue, who also have risk factors that we really need to manage. There's going to be limited availability. I see this kind of being more like the cochlear implant market, where you're going to have certain specialized centers that have the programming capability. And we are fighting the battles with insurance now. These are some of the commercial insurers that have approved it. The VA system has improved it. So if any of you guys work at a VA, have at it, because this is, but select your patients well and start doing it. We've had good success with Medicare carriers. So, which is good and bad. I mean, we're having my average patients I've been implanting now is about 70. I would like to implant people in their 30s and 40s. But the insurance companies are giving us a little harder time, but we are having some success. So in summary, the group that demonstrates the most promise are people with lower BMIs, AHIs between 20 and 65, and drug-induced sleep endoscopy without circumferential collapse. It has low morbidity, excellent safety profile, high level of patient adherence, but we still have some work to do with payers, but it's improving. So I do want to get you guys interested and get you guys to take it to the next level. And because I think it's a group effort that we're trying to do. I do want to mention my sleep course for any of those folks who want to come down. Usually February in Charleston is quite mild. By then you will have experienced some winter. and hopefully we can get you to come down. It's a great course. We do cadaver dissection, sleep endoscopy, home sleep testing, oral appliance, robotic sleep surgery, hypoglossal nerve stimulation, hypopharyngeal procedures, and office-based snoring surgery. So thank you very much. Do we have some time for questions? Yes, sir.
Great talk. I have 2 questions. Obviously, for most of us who operate on the hypoglossal nerve, we don't trace out the branches. I assume to do our first case, you would probably have to do some cadaver dissection. And 2, once you've learned to do this technique, and now speaking to yourself, have you had cases where you implant it and you stimulate and you see very poor tongue mobility, or the amount of tongue mobility is less than what you would like to see? So would you at the same time do any kind of tongue-based procedure?
Dr. Gillespie, can you just repeat the question?
Yeah. So the first question was whether cadaver dissection is important, and yes, a cadaver dissection is important. I think as surgeons we often think we already know it, but as you know, that's not the case, and it's very important to go back to the lab to look at these things in kind of a leisurely setting, low stress setting, and really learn the anatomy. The anatomy, it's one of those things that once you see it, you can recognize it. So it's important to see it in a low stress setting and then learn the appropriate place to put the device. The only problem that you won't experience in the cadaver that you experience in reality is that typically that nerve has a vein running on the top of it, and that vein is a little bit troublesome, honestly, because it's not a big bleeder, but it'll bleed, it'll get in your field, and when you're around very delicate nerve branches, that can be a bit of a hassle. So that's the one thing you won't experience in a cadaver. The second question was whether or not any patients that I've seen have had poor response to the point that they needed other hypopharyngeal procedures. And the answer to that is no. This is a completely adequate treatment for the base of tongue and the airway. Now, that's partly because I'm selecting my patients well. So is there a role for partial glossectomy or robotic glossectomy? Yes, I still do those procedures. But those are patients, largely in my practice, who don't fit this model. Those are patients who have Friedman scores of 3 and 4, who have hugely bulky tongues, and often HI that's out of the range of this therapy. So those patients actually do benefit from, but for the patients in the range, I think that this is wholly adequate therapy. I've had 2 patients where I was unhappy with their response. One patient actually was the one that I showed you on that video that had excellent motion. What I found, the reason I got that video is because I had taken him back. I couldn't figure out why it was not working for him. Took him back to the OR to find out, and he had the tendency to allow his mouth to open during sleep. And whenever his mouth was open, the therapy did not work as well. But as soon as I just lifted his chin, the therapy worked. So we actually got him situated with a chin strap, which he wears, and now his therapy is working. I've had a second patient with that same issue as well. So there is some of his jaw position, tongue position. So if the jaw is malpositioned, it can actually malposition the tongue where the therapy doesn't work as well. So any patient where you're having inadequate response, you may need to take them back to do a sleep endoscopy and investigate what's going on. But I've done 20 implants, and those were the only 2 that have been, for some reason were not responding like I expected them to. So
intraoperatively, you do your first couple, and you're not getting a response that you would presume that maybe technically you haven't.
You should get a response. Yeah, you should get a response in the OR. So now, if you over manipulate the nerve, obviously you can get a paresis, and the best you can do is make sure that the cuff is in the right location and close up and let the patient recover. But the hope is that you can, even in a weak nerve, if the nerve's functionally intact and hasn't been cut, you should be able to get some stimulation out of the tongue. So. Yes.
About the circumferential collapse and the superior laryngeal nerve, have you been looking into maybe stimulating that nerve that may actually result in a better motor and more global motor response?
So the question was whether there's been any thought of stimulating the superior laryngeal nerve. So the nerve branch that's actually involved is not the external branch of the superior laryngeal nerve, it's the internal branch. So it's the sensory branch of the superior laryngeal nerve. And so it's really a sensory function. We found that patients with sleep apnea have reduced sensation to negative pressure changes in their airway compared to normal people. So as far as I know, there's not been any investigation of how to enhance that effect. But I think you're on to something that perhaps we could not just worry about the motor aspects of the airway, but the sensory aspects as well, and what can be done to enhance responsiveness to changes in airway characteristics during sleep. So, Dr. Ottman.
Thank you, Boyd. I want to know a little bit about how the patients approach this, how excited they were about looking at this treatment and getting this treatment. And also, we have a very multidisciplinary practice. We work a great deal with dentists and with surgeons. But what's the general sentiment in the sleep medicine community? Are you meeting some inertia there? And tell us your thoughts.
So the one question was, how are patients responding, or what's their level of interest? Their interest is sky high. Okay, so there's a lot of patients out there who have gone through our usual protocols for sleep management who are unhappy, dissatisfied, and whose CPAP is collecting dust. And they're constantly searching the web, looking for something new. So you have to be prepared. The floodgates, once you start offering this, will open up because there's going to be this undertreated group of patients who are going to show up at your doorstep to see if they qualify. So you have to be prepared for that. And you also have to be prepared for other things to offer them if they don't qualify. So, and that's actually one of the arguments that you can make with your hospital system, because this is obviously expensive. It's risky. I think these come in a pack of 4. So if a hospital decides to do this, it's an $80,000 investment right off the bat. So, but there's actually good data that show that you're seeing 7 to 8 patients for the one that you implant. Those patients go on for treatment, sleep studies, different things. It's a win for the hospitals, and that data exists, and we can get that to people. Patients are very excited, and they've been our greatest ambassadors. One of my patients, he was a businessman. He had bad relationships with the media in the past, and the first thing he told me before we did this implant was, I don't care if it's the best thing in the world, I'm not speaking to anyone about it. I've had I don't like my words twisted by the media, and I'm not. Afterwards, he was so happy. He came to me and said, I want other people to know about this, and I want to get the word out. And he's done some blogs and done some podcasts and things to try to make people aware of this. As far as the sleep community, I think it's not so much there is inertia, and I think that's the proper term. I don't think it's any opposition to the therapy. I think it's more of not really taking the time to learn about it. And I went out, I canvassed my state, seeing pulmonary sleep physicians, and my referrals were close to this. We did the company ran a direct to consumer radio campaign, and people showed up. So I think it's one of those things that success will speak for itself. I'll try to continue to work with my other colleagues in sleep. I think the results will, as they start accumulating, this therapy will make sense. But for patient care, I think it would be best to have, a comprehensive sleep approach with pulmonologists, with surgeons for this.
Listen, we really appreciate it. It was a terrific presentation and very informative.
Thank you. Appreciate it. Thank you.
I believe that you've got M&M here? Not today. Okay.